Move forward with the topic of 10 best practices changing paper and respiratory critical care. Chairpersons for the event are Dr. Yagnang Vyas, pulmonologist at Naryad, Dr. Harshal Soni, he is a physician at Khambhat, Dr. Jaimeen Mansuria, he is a consultant pulmonologist at Anand, Dr. Arpan Shah, he is physician at Anand. I would like to request the chairperson, Dr. Arpan Shah, to introduce the speaker.
Harjit Dumra, sir. He is an MD in internal medicine, a consultant transplant pulmonologist, sleep medicine and critical care specialist from KD Hospital, Ahmedabad. He is also a director at Sparsh Chest Disease Center. He has done his training in pulmonary and critical care medicine from KIMS Hospital, Mumbai, and observership at Cleveland Clinic, US. He is also an honorary pulmonologist and critical care consultant to His Excellency, the Governor of Gujarat. Also a teacher in DNB Critical Care and teacher for IDCCM, that is Indian Society of Critical Care Medicine Fellowship Program. His areas of interest include critical care, pulmonary hypertension, interstitial lung disease, lung transplant and interventional pulmonology infections. Numerous papers in his index medical journals, authored in chapters in the textbooks of pulmonary and critical medicine. Thank you, sir. Welcome.
Thank you, Mr. Chairperson, for those kind words of introduction and to the topic at hand. I'm trying to summarize a lot of data over the last 1 to 1.5 years and trying to bring you papers which are relevant to your clinical practice. So as you leave this hall today, maybe you'll have some points to go in and implement these issues which bother you in day-to-day practice. So this is my practice changing paper list. It might differ from yours, but this is what I thought was clinical relevant. I'm going to use a vignette of a case just to sort of get it into context. So this is my patient. He's a 69-year-old male accountant, non-smoker. His weight is around 72 kgs. He exercises regularly. He has comorbidities of hypertension, dyslipidemia. He's also having rheumatoid arthritis, for which he is on methotrexate 15 milligram a week in addition to his other drugs. He presents with history of episodic cough, maybe 2 to 3 times a year, which has been treated as bronchitis in the past. He also had a flare-up of his joint pains around a few months back, for which he needed steroids for nearly 3 months. Now, this patient presented to the ER with complaints of low-grade fever since the last 5 days, along with cough and respiratory distress. On the day of admission, he had altered behavior and he was hypoxic. When he comes to the ER, he has mild fever, he's tachycardic, he's hemodynamically stable, and his SATs on 10 liters of oxygen is around 93%. He was wheeled in from the 108. This is what his X-ray looks like, which we get in half an hour's time. Also get an ABG done. As you can see, he's significantly hypoxic, but apart from that, there's nothing on the ABG. Some additional investigations which we got in the next couple of hours showed that his sodium was low, mild elevation in hepatic enzymes, creat was borderline high. We also got a bedside echo, which did not show anything significant apart from concentric LVH. This patient was labeled as severe community-acquired pneumonia. And these are the questions which we tend to encounter when we see a patient like this coming into the emergency room. What about the newer investigations? What about the role of macrolides apart from routine antibiotics? There has been a lot of talk about steroids. And what do we do as far as respiratory support goes? Do we go with high flow? Do we go with non-invasive? And to answer these questions, I bring up this first paper. This was the ERS guidelines for management of severe community-acquired pneumonia, published in 2023 in the intensive care medicine. In fact, this is the first consensus or guideline statement for severe community-acquired pneumonia. Most of the guidelines till date have been on community-acquired pneumonia, which have also addressed severity, but not specifically focusing on this particular modality, severe community-acquired pneumonia. Just to set the ball rolling and get it clear, what do we mean by severe community-acquired pneumonia? Any patient coming to the ICU with the use of either requirement of vasopressors or ventilation will be labeled as severe, although there are other criteria which you can go through. Why are we looking at this? Because it has extremely high mortality when you see a patient in septic shock and needing ventilation. So the first question, should we send multiplex PCRs? A lot of you have access to it. So what they have said is, in case you want to change your routine antibiotic spectrum, so usually we go with ceftriaxone, ampicillin, maybe amoxiclav, and fluoroquinolones or macrolides. If you want to change that for some reason, so suppose you're suspecting an MRSA, suppose you're suspecting a viral infection, suppose you want to go with a dual combination of drugs. In those groups of patients, a multiplex PCR is beneficial. Why? Because if you want to up titrate at least you get the bug up front, so you don't miss out on the bug, and you are quick and prompt about appropriate antibiotic therapy within the next 6 to 12 hours. It has its problems because these are expensive investigations, and sometimes they can be false positives. So you might over-treat because even a colonizer might be picked up. So when using a multiplex PCR, use it when you want to either escalate from the routine or you want to de-escalate. Suppose you're giving an antiviral, but the multiplex PCR does not show a viral infection, you can de-escalate. It's preferable to go with high flow nasal cannula, and there is reasonable data that it is better than NIV in patients with hypoxemic respiratory failure, particularly with severe community acquired pneumonia. Macrolide is preferred over fluoroquinolone. More than certain sufficient data which shows macrolide better than fluoroquinolone in severe community acquired pneumonia as far as mortality goes. PCT is used to de-escalate therapy. Oseltamivir whenever you suspect or you have a positive PCR. What about steroids? Because there is a lot of data coming up with steroids, and the quality of evidence is low, and the trials have been biased. So there has been a lot of data about decreasing length of stay, improving clinical cure rates, and particularly in patients with shock. The guideline says clear cut that if you have shock, use steroids. But if you don't have shock, then use steroids judiciously because the data is not so strong. What about prediction scores to identify drug-resistant pathogens? Many times what happens is that you'll have patients coming into the hospital who are severely ill. You want your first antibiotic to be the right antibiotic. At the same time, you also have to think of drug-resistant pathogens. So they have advocated use of algorithms to identify if your patient has a drug-resistant pathogens, because your gut feeling might differ from mine and we might overtreat or undertreat. So this is one of the algorithm by Niederman came up in clinical infectious disease. You can go through this in the literature. And the last bit was, what do we do if we suspect aspiration? Should we change our antibiotics if there is aspiration causing community acquired pneumonia? The answer is no. Most of your antibiotics, whether it is coamoxiclav, ampicillin, fluoroquinolones like moxifloxacin, would have sufficient anaerobic coverage. So no need to add clindamycin, meropenem, just because you have aspiration causing severe pneumonia. So these were the practice changes. Like I said, steroids only in shock and no extra antibiotics for aspiration, and multiplex PCRs if unusual presentation. Now this patient was needing 10 liters of oxygen. So the next question would be, would you start him on a respiratory support? And these are the options you have: HFNC, face mask NIV, and now quite a few of us have started using the helmet NIV. And again, this data comes a little back from 2015, where we had the Florari trial, which compared HFNC versus NIV versus standard oxygen therapy for hypoxemic respiratory failure. And what they found out was that regardless of the modality, the mortality only showed difference at 90 days, but the intubation rate remained the same whether you used any of the three. So it did not make a difference to the intubation, but at 90 days, there was benefit in mortality. Now, when they analyzed this data, they found that in patients on NIV, where the mortality was higher at 90 days, they had been using HFNC intermittently to give breaks. And possibly the time to intubation in the three arms, standard oxygen therapy, HFNC, and NIV, was the same. So it was the strategy of oxygenation, not the time to intubation, which made a difference to the mortality. And what they found out was that in patients on NIV, the expiratory tidal volumes were pretty high, which led to patient's self-inflicted lung injury, worsening the condition, and that is why maybe the mortality was high. So what was concluded was that HFNC possibly decreases self-inflicted lung injury, and that is why it might be a better option as compared to face mask NIV. Now the problem is that with face mask NIV, the maximum PEEP you can give is around 5 to 8, because the moment you increase the PEEP, leakage will start from the mask and you will not be able to achieve high PEEP. Now high PEEP tends to decrease self-inflicted lung injury because it decreases the intensity of the respiratory effort and it decreases respiratory rate, and both of them will prevent self-inflicted lung injury. So is there a way we can increase the PEEP when we use NIV? Now these are the different masks which we have. Helmet, this is the face mask, this is the full face mask. Only with the helmet, you can go up to a PEEP of 10 to 15. So what is the target? In hypoxemic respiratory failure, if you have a patient in respiratory distress, HFNC is better than NIV. But if you go for a helmet mask, where you can deliver higher PEEP, maybe you can decrease the respiratory effort, and hence you might be able to decrease the self-inflicted lung injury. Maybe it might lead to lesser mortality. So is this hypothesis correct? This was tested and came out in the JAMA. This was particularly for the COVID-19 patients. So they compared HFNC versus helmet NIV. And they came out, this was a negative trial. So they did not find any benefit. Now this was also subjected to post hoc analysis, and they looked at a subset where the PaCO2 was high and low. So if you had a PaCO2 of greater than 35, which clearly indicated that the respiratory rate was under control, the mortality was the same. But if your PaCO2 was less than 35, which means in patients who had high rates, high tidal volumes, the mortality was much lower for the helmet versus high flow, clearly indicating that in patients with lower PaCO2, that is the segment you might try helmet NIV instead of face mask NIV or HFNC. So these guidelines came in the NEJM, and I would urge all of you to read this because this is an excellent paper, came in 2022. If you have a patient with severe ARDS or severe hypoxemia, PF ratio less than 100, please intubate, do not wait. In patients with moderate hypoxemia, that is between PF of 100 to 200, if the PF ratio is less than 150, again it is better to intubate. But if you are going to wait, then it is better to go with a helmet NIV rather than an HFNC if you have that facility. So in PF ratios 150 to 200, we have signals coming up, and this is the practice changer, that instead of face mask NIV, use helmet NIV, where the PEEP can be increased, improving patient self-inflicted lung injury, decreasing your mortality. Just because we are on the subject of non-invasive ventilation, this excellent paper in the JAMA came to a conclusion that during COVID, we had a lot of apprehension when we used HFNC or NIV that it is causing aerosol generating. It's an aerosol generating procedure, increasing risk of transmission to medical fraternity. This paper clearly showed that that is not the case. So in the next COVID pandemic, or for example, the next time you have a pandemic with viruses, if you are entering a patient's room with HFNC or face mask NIV, you do not need to take extra precautions. That part is clear. So this patient, because he had altered behavior and he was vomiting, we did not give him helmet NIV. We went on to a trial of HFNC. He was started on ceftriaxone, azithromycin, and oseltamivir. The nasopharyngeal swabs came back as negative. His PF ratio was 160. Now the question is, does this patient have ARDS? Remember I told you, severe community-acquired pneumonia is the commonest cause of ARDS. So this was the previous definition of ARDS, the Berlin definition, and the new definition came up in 2023. Again, it simplified a lot of stuff. First, it showed that intubation is not mandatory to classify a patient as ARDS. A patient on oxygen can also have ARDS, and it helps us pick up ARDS early. Secondly, you need not have an ABG to classify a patient as ARDS, because previously we were going by PF ratios. Now you can go by saturation by FiO2 ratio, and if the patient's level is less than 315 with a SpO2 of less than 97, this patient can still have mild ARDS. Thirdly, you don't need a chest X-ray or a CT scan. With the bedside ultrasound, you can still classify a patient as ARDS, and all of this simplifies management in resource-limited settings, so you don't need an ABG. You can go ahead with an ultrasonography, and non-intubated patients can also have ARDS. So the highlights in the blue are the new additions to the guideline from the Berlin definition. So what it does as practice changes is no longer wait for patients to go on to high flow. Even a patient on oxygen can have ARDS. So pick up ARDS early. Why? Because even till date, we don't have any therapy which improves mortality in ARDS when we treat ARDS. It is the etiology. But as far as ARDS management goes, we still don't have any effective therapies. So the only therapy is supportive, which means we have to prevent iatrogenic lung injury. And that can only be possible if you implement ARDS net protocols early in management, and that is only possible if you identify ARDS early. So those are the key points. Now this patient who was started on HFNC was comfortable, his sensorium improved with hydration, but he still continued to be tachypneic and tachycardic. Would you consider awake proning in this group of patients? So this was a guidance coming up in the Journal of Critical Care in 2023, where they looked at two segments: awake proning in patients on respiratory support like HFNC and NIV, and awake proning in patients on conventional oxygen, and they divided into COVID-19 patients and non-COVID-19 patients. The evidence only came up for patients of COVID-19 who needed artificial respiratory support, which means HFNC and NIV. The evidence was not positive for patients only receiving oxygen. Practice changing positions, that maybe patients on oxygen therapy are not as sick that awake proning with benefit. Also, if your patient is not sick, he might not tolerate prone positioning for very long times, and the minimum duration you need is 8 hours. So consider a patient who's not very sick, has 8 liters of oxygen requirement. You turn him around, he's going to turn back in a couple of hours. So maybe it is not practical. So look at the severity of oxygen support which is needed, but it cannot be the only criteria, because sometimes you might be on an FiO2 of 80%, the patient has severe hypoxia, but the patient is comfortable. And sometimes you might have an oxygen requirement of 6 liters, but the patient is not comfortable, and this patient might benefit from proning. So use this thought judiciously. So we gave him a trial of awake proning. It did not help a lot. He was a little stable, so we could wheel him into the CT. And as you can see, these were the scans. So he has basal ground glasses, but there was a lot of reticulation and interstitial thickening. So the radiologist came back and told us, this is bilateral pneumonia, but he has possibly got an underlying occult ILD from the rheumatoid arthritis, which we have not picked up till date. This patient was not symptomatic for ILD prior to this event. Remember, he had frequent episodes of bronchitis. So we said, this patient has been given adequate antibiotics. He seems to be stuck up on an FiO2 of 50, doesn't seem to be improving. Let's give him a tinge of steroid. By day 7, this patient now worsened. His FiO2 requirements on the high flow climbed up, and he also had to be initiated on low dose vasopressors. So that brings us to the question, what would be your first choice of vasopressor, and how important is this central line when you initiate vasopressor? Excellent written paper in the chest, practical. Read this, came out in 2023. How do you use vasopressors in your ICU? The first thought is we always go with norepinephrine, but in a patient with tachyarrhythmias, the first choice vasopressor can be vasopressin or phenylephrine. Think about these things. So vasopressin is available. So if the patient has a heart rate of 160 or has AF with fast VR, you can try vasopressin as your first vasopressor, because norepinephrine is not the drug of choice. What about the first few days with or without a central line? So there is clear-cut evidence that for the first 48 to 72 hours, a large bore IV cannula will not cause significant extravasation, and you can get away without a central line if the vasopressor dose is low and if you are going to use it briefly. So you are not in a hurry to put in a central line. If your septic shock worsens, what is your second choice vasopressor? Usually we say it is vasopressin, but in younger patients, patients with septic myocarditis, or patients who have Raynaud's or digital ischemia, epinephrine becomes your second vasopressor. It is not vasopressin. As you step up with vasopressin, when you wean vasopressors, noradrenaline usually is weaned the last, vasopressin is stopped first. That is no longer the case. So stop norepinephrine first, because now there is sufficient data which says that vasopressin should be continued and should be stopped last. Norepinephrine should be stopped early, because hypotensive episodes are much faster if you stop vasopressin early. If your patient still has refractory shock, then you reassess, look at other causes of shock. It could be a patient of septic shock has now developed cardiac shock or hemorrhagic shock or adrenal insufficiency. Do not always rely on your central or your arterial line, because sometimes it might give you wrong readings. There might be damping. It might be not be in the wrong position. It might be in the wrong position. If there is acidosis, correct it. So there is data that if you have renal failure related acidosis, correct with bicarb to a pH of 7.34. And you can try methylene blue as a salvage. And there is data coming up, although the evidence is not very good. Now, if your patients, many times I have seen that you are stuck up in the ICU with low dose vasopressors, the patient is on 1 or 2 ml of Norid, and you can't shift this patient out of the ICU because this blood pressure just goes down as soon as you stop noradrenaline. Delays leads to prolonged stay in the ICU, infections, cost, mortality. So in these groups of patients, there is emerging evidence for midodrine, and now there is off-label use of midodrine in patients specifically with renal failure, liver failure, and patients with epidural analgesia or anesthesia-related hypotension. The dose is 10 to 20 milligrams 8 hourly. Emerging evidence, but use it wisely because you'll be able to shift your patients out of the ICU early. So those are those bits from this paper. Now, our patient continued to worsen over the next 24 hours. He needed intubation and ventilation. Now we were considering him as a patient of nosocomial pneumonia. Remember, this is day 7. He develops a fresh bout of fever and respiratory distress. He is immunocompromised. So we put in a central line. His vasopressor requirement had increased, and now he was on neuromuscular blockade agents. So what should be your oxygen targets in patients initiated on mechanical ventilation? And there has been no dearth of trials targeting low, intermediate, high oxygen, but still the debate continues, what is the best? There have been trials which have shown that if you target very high saturation, it leads to oxygen-related lung injury. There have been trials which have shown that low targets need not be better. So this particular trial was a pragmatic trial, came out in the NEJM, again a very good trial. They compared 3 targets, low saturation 90 versus intermediate 94 versus high, that is 98. And what came out was, regardless of the level targeted, there was no benefit in the ventilator-free days or mortality. So whether it was acute myocardial infarction, whether it was cardiac arrest, these are situations where we target high oxygen targets, or it was septic shock where we target low oxygen saturations. Regardless of the subset of patients, the 3 targets showed the same level of mortality and ventilator-free days. So those of you who are targeting high need not be worried, but always try to go with an intermediate levels, but all targets for the day are safe. There is still another trial coming up. Maybe the next time Abhishek invites me, I'll give you the data for that trial as well. So the next one was, this patient needed an FiO2 of 70 after optimizing ventilatory management. Blood cultures were sent, a beta-glucan, procalcitonin, galactomannan, all the biomarkers were sent, and we also needed respiratory secretions because he had now developed a nosocomial pneumonia. So what do? Send endotracheal aspirates or consider a BAL? Which is better? FiO2 of 70, severe ARDS, day 2 on the ventilator, maybe day 1 as well. Or are there any other options? This is a paper I picked up because this is relevant to the Indian context. A lot of times BAL is not possible. You might not be able to do it in the middle of the night. Your pulmonologist might not be available. The patient has high requirements. You might in fact worsen the patients. So sending tracheal aspirates sometimes is not advisable because false positivity rates are high, particularly in the immunocompromised. So when you're looking at immunocompromised, you want more specificity, and BAL is better than tracheal aspirates. But BAL is difficult, so look at non-bronchoscopic BALs. And I would advise you to read Dr. Khilnani's paper from 2011. This paper came out from AIMS, and they have beautifully described the methodology to do a mini BAL using catheters. And this is something which we all can do. Now, this meta-analysis had 2 studies from India, so it is relevant to our country. This can be done. What they showed was the sensitivity and specificity of a mini BAL done with catheters is almost the same as BAL done with a bronchoscope. So sensitivity good, specificity good, it can be a cost-effective, simpler and a safer substitute. So try it out in your ICUs. The next time when you send a tracheal aspirates, if you have 15 minutes extra, this might give you better results. So we did a mini BAL, empirical change of antibiotics. Our dominant bug is Klebsiella. So what would be your empirical antibiotic in this patient? And would you consider inhaled antibiotic, as somebody was just asked in the previous session? So the IDSA came out with guidelines for gram-negative resistant bugs, and I'm not going to dwell a lot of time on this because Parikshit has already covered most of it, but this is for CRE. Combination of ceftazidime avibactam with aztreonam is the norm because we have a lot of NDM. Alternative options are tigecycline, but not to be used in urinary tract infections and bloodstreams. Polymyxins should be avoided, and combination therapy is not suggested for CRE. Moral of the story, we should be avoiding polymyxins as far as possible in our ICU, and by and large avoid inhaled antibiotics. This is the guidance from IDSA for CRE, CRAB and DTR pseudomonas. Out of that entire document of 118 pages, if you need 3 lines, take this home. Now, what about inhaled drugs? We commonly use a lot of inhaled drugs in our day-to-day practice, bronchodilators, sometimes mucolytics, occasionally antibiotics. And that is what brings us to this important paper, when you are using inhaled drugs, what care do you need to take? Because we use such a lot of them, but we seldom are basically focused on what we should be doing. What about the nebulizer? What about the ventilatory settings? How much is the dose? How frequent should be? What care to be taken? So beautifully written paper, 20 statements. I can't go through all of them. I'll just focus on the invasive ventilation part. So first, don't change airways just because the diameter of the endotracheal tube is narrow. Doesn't mean it will affect the delivery. If you are using an HME, use a bypass rather than disconnecting the HME today, because now we have HMEs with bypass for aerosol therapy. I have stopped using a PMDI spacer. The fill volumes, whether less or more, will not make a difference to the delivery. If you are using an inline humidifier, previously we said stop it because the humidification in the tubings will lead to deposition of the drug in the tubing. This will decrease the delivery to the lung. No longer the case. Why? Because even when you stop the humidifier, it takes a couple of hours for the humidity to go away. So if you are nebulizing immediately after stopping, it makes no difference. And if you fail to switch it on after the drug has been delivered, you will lead to a lot of drying of the airway. So please don't do it, but now use HMEs with bypass. We always used to think we need to change the ventilatory settings when we are nebulizing. Low rates, more inspiratory time, inspiratory pause, a ventilation modality of volume control cycle ventilation. Now it is said, do not change ventilatory settings because the synchrony is most important. If you change the ventilatory settings, it will also affect the delivery if it is not the right setting. So a lot of pluses. Lastly, vibrating mesh nebulizer is the best nebulizer to go with. Jet nebulizers are out. Use inline nebulization. Don't connect it from outside because it affects the tidal volumes, the respiratory rate, it destroys the ventilator mechanics. So as far as possible, use a vibrating mesh. You can read this paper, I'm going to speed up a little bit, but there is data on high flow and non-invasive as well. So inline nebulizers, do not interrupt ventilation when you nebulize, do not change ventilatory modes, vibrating mesh is better, and bypassing the HME is the best options. So this patient was started on a combination of ceftazidime, avibactam with astronam, and he was given linezolid because it was empirical. We sent a BDG, remember, it came out as positive, 180. Would you consider giving him an antifungal based on the BDG? And this question was beautifully answered in this paper in intensive care medicine. This is called the CandiCept trial. They looked at patients in septic shock who were at high risk of invasive candida infection. So these patients were on renal replacement, they were on parenteral nutrition, they had undergone abdominal surgery, they had received previous antimicrobials. So they wanted to see if early identification of a positive BDG would lead to early use of antifungal, would lead to improving mortality. So if you see, the time to antifungal therapy in the BDG arm was 1 day versus 4.5 days for the control group. But if you look at the mortality, it did not improve. Clearly showing that you should not be relying on the BDG. A culture-driven strategy possibly still is a better way to go. Why? Because a false positive BDG leads to excessive use of antifungal in the ICU, more resistance to the antifungal, more problems down the line. But you can use the BDG to de-escalate. So just as procalcitonin is used to de-escalate, a negative BDG, and if you have started with an empiric antifungal, can be used to de-escalate. I will take a few more minutes if it's possible, 3 or 4. So what about BDG? Excellent negative predictive value, but if you want to improve the positive predictive value, go with serial sampling. Send one. After day 2 or 3, send another if the first one was negative or the first one was borderline positive. A rising BDG favors use. Combine BDG with a low PCT, that indicates a better possibility. The sensitivity of the BDG varies with the species of the candida. So if you are having parapsilosis or auris, the BDG can be falsely negative. But if you have albicans, the BDG might be positive. So remember, a low BDG can still be positive candida. And lastly, you can also use peritoneal BDG in patients with intra-abdominal infections in addition to systemic BDG. So this was about BDG. So we started him on medium dose of vasopressors. After 12 hours of ventilation, FI2 was 70, plateau pressure was 36. He was having a PF ratio of 100. We had labeled him as severe ARDS. What would you do next? Recruitment measures, proning, ECMO. So the ARDS guidelines came out. 2 societies came out with these guidelines. The first one was the ATS, The second one was ESICM. Both came out in the last 1 year. Long list, focusing on the ATS, 4 main things which came out. Neuromuscular blockade in patients with severe ARDS in the first 48 hours. VV ECMO again with severe ARDS. Systemic corticosteroids across the board, a lot of controversy in this, and we can take this up in the question answer. High PEEP for patients with moderate to severe ARDS, negative for prolonged recruitment measures. Now the ESICM did not make a recommendation on these 3 important things, and there is a lot of debate and controversy, and hence we are still not sure. Again, read this ATS segment, and I'm not going to focus on this, but a lot of data in this segment will help you identify which are the patients to use steroids, where should you consider neuromuscular blockers, and how do you titrate PEEP. All of this in this guideline. One size does not fit all, so phenotype your ARDS and justify your PEEP according to the phenotype. Now this patient was given proning cycles, plateau pressures were still high, we had done a mini-bal, it grew Klebsiella, we withdrew linezolid, tracheostomy was done. This patient became hemodynamically unstable a couple of days down the line, and he started requirement, although he was not, his FiO2 went up, but he was still hemodynamic stable. We repeated a CT at this juncture, and the differential was, did he have an acute exacerbation of ILD? Remember, the pneumonia now could have triggered an acute exacerbation. So any data on fibrotic ILDs and acute exacerbation? Again, a lot of data, but what it shows is that if a patient with fibrotic ILD worsens, the incidence of mortality is extremely high. We are talking about fibrotic ILD, not inflammatory ILDs. And if they require mechanical ventilation, the mortality is still higher. This paper came out in the ACR in rheumatology, and this, at least for connective tissue disease related acute exacerbation of ILD or rapidly progressing ILD, shows that high dose of steroids with 1 immunosuppressant like cyclophosphamide or rituximab, or 2 immunosuppressants, if you have rapidly progressive or MDA5, still might give you some leverage. Read this paper. What is most important is if the patient goes on mechanical ventilation, high rate of mortality, so send these patients for lung transplant if they recover. So if a fibrotic ILD goes on ventilator, gets weaned off, refer for transplant. Fine, so this patient, we increased the dose of steroids. We wanted to give him cyclophosphamide, but the patient worsened. He had started having episodes of AF, eventually went into cardiac arrest. Last concluding papers, would you consider eCPR? Would you want to go for therapeutic hypothermia? Because these are certain things which are coming up. So the AHA came up with the new recommendations in 2023 in circulation, very recently released, which shows that if you have the access and facility and the skill to use eCPRs, it is better because the recovery at 6 months and discharge mortality is better. But if you don't have eCPRs, please do your conventional. What about temperature control? Now there is no benefit of cooling to low 32 degrees. In fact, 37.5 or 99.5 in the first 24 hours is sufficient to give you good results. Seizure management. So start an anticonvulsant, a non-sedating one, levetiracetam, lamotrigine, could be ones which you could use after cardiac arrest if the patient does not become conscious, because it has a bearing on mortality. Consider organ donation for these patients. Last slide. A lot of focus now coming up into palliative care in the intensive care unit. So be compassionate. If you can't do the job, at least give them a comfortable death. And there is a lot of focus on going green in the ICUs. A lot of plastic waste being generated. Just one example. We use a lot of IV paracetamol, generates a lot of plastic waste. So this paper just cut down on the use of IV paracetamol to oral paracetamol. And that cut down the carbon footprint of their wastage significantly. Suppose all of us in all our ICUs do that, you can very well imagine how better we can make our environment. So these were the key points. I have done more than 10 papers. I have exceeded my time a little bit, but I am happy to say I have covered most of what I wanted to, and I am open to questions. Thank you for a patient listening.
Well, thank you very much for this excellent presentation, sir. We are open for questions right now.
If the patient has a background history of rheumatoid arthritis and the patient goes on steroid, as a physician, do you think that when he comes with pneumonia, your approach should be a little bit more
So we got an HRCT as soon as we could, because sometimes the patients are in distress. The first dictum is manage and then identify the etiology. Now this patient was not on systemic steroids when he came. This was a patient on methotrexate. So the systemic steroids were not on the patient. But if you have an immunocompromised patient who has been on significant and prolonged duration of immunosuppression, my recommendation would be that yes, go with the CT, and if possible, look at an opportunistic bug with a BAL if you have ruled out community acquired pathogens. Fine? Yes? Okay, so first and foremost, we have been sending a lot of BDGs, and that is why I brought up that Candicept trial, because a positive BDG has led to overuse. Just as a positive procalcitonin leads to overuse sometimes, even in viral infections, your PCTs are high. So first and foremost, go clinically. It has to be in the context. Is the patient on broad spectrum antibiotic? Is it the patient has been on in the ICU for more than 7 days? Are there risk factors? Are there colonized sites like the first talk we had, whether you have candida colonization or not? And then if you want to give empirical antifungal, always send a BDG. Why? Because a negative BDG on the next day will help you de-escalate. So don't start without sending that BDG. Now, the data for antifungal is clear. If you are in shock, then it's best to go with an echinocandin. If the patient has received a previous azole, it is better to go with an echinocandin. But if you ask me about my ICU, if the patient has a fever on day 9, the patient is hemodynamically stable, I have not used an antifungal, I would still prefer fluconazole, because a lot of my candida is still azole sensitive. But you'll have to look at your ICUs as to what is your empiric choice of antifungal. Fine. Okay, thank you.
Thank you very much, sir. It was an excellent presentation. Thanks.